Well, welcome to our monthly webinar. This time we're going to talk about an autoimmune disorder. We're going to do a case study. It's pretty cool because we have a class in Rolla, Missouri, where we're doing a DAPC, and I think we're at session 5 or 6 or 7, something like that. We're getting into the program, and this is actually a case study that one of the students sent in to me, and quite frankly, I've looked at it briefly because I wanted to actually go through this kind of fresh. I didn't want a canned plan walking through. I want to kind of make it more like real time. I'm looking at this. This is where we're going with it. So I really haven't had much time to really go over this case study. Not because I was being lazy, but because I wanted to keep it more spontaneous. I have a lot of things to go over in here. So I think this might be a fun class for you guys, and I certainly hope you learn a lot out of it. Your labs came back all good, so there's nothing wrong with your thyroid. Don't you just love that right there, right? Okay, I thought this was an interesting concept here. This is back before the 50s. Didn't really have any idea that autoimmune even existed. The concept of autoimmune as the cause of human illness is relatively new. In fact, Paul Ehrlich, which is the great German immunologist, he said if there's a way that the immune system would actually attack the body, they should call it literally horror autotoxicus. You know, autoimmune diseases, there's over 100 different types that we know of, but guess what? There are about 200 cell lines in the human body, 200 cell lines. You know what that means? They're going to come up when they're all said and done. You're probably going to find there are 200 autoimmune diseases, because all tissue, if it has significant amino acid sequencing or other factors that we talk about in the autoimmune module, if it has certain factors, it can cross over, and if it crosses over, the immune system loses its ability to differentiate between what is normal and what is body tissue and what is not. Now, just as a brief review, we kind of all know this, but I want to make sure we foundationally don't miss a few concepts. Number one, the immune system, of course, is supposed to go after all foreign and domestic problems, all things that can cause problems. So the immune system is going to have one of three responses, no matter what it's faced with. It's either going to look at something and say, you're not supposed to be here, and I'm going to kill you. That's one response. Number two, you're not supposed to be here, or you're not usually here, but you're not really a problem. You're not causing any problems. I'm going to leave you alone. And the third response is, oh, that's the human body. That's part of me, so I'm not going to attack that. That's the three responses the immune system is going to have when it sees anything. So what happens in the immune system? The immune system loses its way, and there's different mechanisms of why this happens. And as I said, in the autoimmune module, we go through that in depth. We don't have time here to be able to get to the case study, but basically what happens is we begin building antibodies to tissue, and when we do that, there's this process that happens with autoimmune. I'll give you an example. Let me see if I've got a blank screen. I do have a blank screen, so let's take just a moment to look at this. Let's say, for instance, I'm going to draw something just random here. So let's say that I have a molecule that looks like this. Well, the white blood cells have decided they don't like that. They say that's foreign, you're not supposed to be here. And so what it will do is it will build an antibody that will fit right into there like a lock and groove, a tongue and groove, if you will, and it'll lock. And once the antibody locks onto that, then the whole cavalry of the immune system is going to come out and knock that thing out. That's the beauty of antibodies, that it will tag things so that your immune system can come get it. Well, as it turns out, you might have, for instance, you might have a streptococcus bacterial infection, and the strep looks like this. I'm only giving an example. Strep doesn't look like this. It comes down to the amino acid sequencing that you're looking at. But this gives us a visual, so let's go with this. So let's say the strep looks like that, and then you build an antibody for that strep that looks like this. Well, as it turns out, in the base of the brain, here's the nose and the mouth, brain stem. In the base of the brain, you have something called the basal ganglia. The basal ganglia is what turns on and off the brain. So in other words, if you want to move your right arm, your basal ganglia sends a message to the left side of the brain, in homunculus man to turn those neurons on whose job it is to raise your right arm. That's what happens. But guess what? Right now, I'm not raising my right arm. I'm not moving my right arm. You know what the basal ganglia is doing? It's actually sending a message to that area, to those neurons saying, don't move. So the basal ganglia doesn't just turn on movement, but it also turns off movement, and that's an important concept. Well, as it turns out, the strep bug looks similar to the basal ganglia. Amino acid sequences look similar. There's some sequencing that's similar to the basal ganglia to a strep infection. Well, what happens is if the immune system is unhealthy, if it is unhealthy, then it may have one of these antibodies that look like this, right? Sorry about this. Come over here and attack the basal ganglia. Of course, it's microscopic, but it will attack that. Well, when it first attacks it, you might have something that looks like this, like the basal ganglia looks like this, but this guy comes in here like this, and it has somewhat of a fit. So that's autoimmune. But guess what happens over time? Sometimes this can happen in 3 days, sometimes in 7 days, sometimes in a month or so. These antibodies will become better and better and better till finally you have fully crossed over, and now you have something, an antibody that actually perfectly fits in there. Because over time, the immune system will adapt itself to be more efficient to make a better antibody. That's the reason why, you know, when people are sensitive to gluten over time and they have Hashimoto's, over time, the more they eat gluten, the worse their reaction becomes, because the antibodies for the thyroid become better and better and more efficient. And that is a bad thing about autoimmune. It's a good thing to understand, but it's a tough thing that we have to deal with. All right, prevalence. National Institutes of Health estimates approximately 23.5 million. On the other hand, ARDA, which is the Autoimmune Association, says 50 million Americans live with autoimmune disorders. Very interesting. Autoimmune disease is on the rise, no question. We've identified 80 to 100 different autoimmune diseases when they're done. As I said, probably about 200 because we have about 200 cell lines. All right, so here are the prevalence. The most prevalent autoimmune in the United States today is Hashimoto's, and it's 10 to 1, male to female. Lupus is 9 to 1, female to male. I said that wrong. Hashimoto's is female to male, 10 to 1. Lupus, 9 to 1. Sjogren's, 9 to 1. Primary biliary cirrhosis, you can go through the list. The one that starts getting more even is multiple sclerosis, 2 to 1. But as you can see, more women are afflicted with autoimmune than not. Some people think that it has to do with estrogen, has to do with these kind of factors. And of course, more boys are riddled with ADHD, autism, and such. And they say there's similar, there's different mechanisms, but there's some hormonal input to that. Okay. All right, traditional medical care, medical education provides minimal learning about autoimmune disease. But keep in mind, here's the deal, and this is the reason why traditional medicine has such a hard time dealing with, other than giving somebody prednisone, dealing with autoimmune. Because if you look at it, traditional medicine is built upon the infectious disease model. What is the infectious disease model? If you have a bug, here's a drug. So if you have bacteria, here's the antibiotic that fits it. If you have a virus, here's an antiviral. So it's a kind of a one-for-one linear model. So they actually expound that into when they're taking care of people with high blood pressure. What do? It's not about getting to the root cause and what's driving bad physiology, but it's about you have high blood pressure, let's give you a pill to lower it. You have high cholesterol, give you a pill to lower it. You have low thyroid, give you a pill to raise it, whatever the case may be. So that's really the traditional model. And when you look at the traditional model, it's really not suited to really going through what we would call multifactorial issues. Multi means many, and factorial is factors. There's many factors that can drive autoimmune. Like for instance, we know autoimmune, if you have infections, you have food sensitivities, you have different things like this, that it can drive the autoimmune, but it's not the sole cause, and it's not, you don't just stop there. It can be, one person is going to be sensitive to nickel, and it's going to throw them for a loop every time they're exposed to nickel, even something as innocent as cooking with stainless steel, or somebody puts on braces, and all of a sudden they go to an autoimmune because the braces have nickel in it. They're sensitive to nickel. Then that revs up the autoimmune process. The next person, there's no problem with nickel, but they have a problem with mercury, or whatever the case may be. It's multifactorial. You can't just give a drug for a bug and really have good, steady success with these cases. All right, how are autoimmune cases handled in the functional medicine setting? Well, it can actually be very much the same way, just not using drugs. You know, you have one doctor that feels like parasites do everything. So that doctor will, you have come in with autoimmune, and guess what? He or she will find a parasite. You have the next doctor that's the Lyme. This used to bug me. The Lyme literate doctor. I'm a Lyme literate doctor. Well, you know, what that means is if you go see this doctor, he or she thinks everything's Lyme. So you come in, you have lupus, you have Hashimoto's, whatever. Oh, it's Lyme causing it. Or you have another doctor that's a heavy metal doctor specialist, like everything's heavy metals. He does urine tests on everybody, chelates them, finds loads of mercury, loads of lead in everybody, and that's what he does, or she does. So you get the picture. So we can do this and make this mistake in alternative healthcare and just thinking that things fit our model. Autoimmune, you have to throw all of these models out. You're not going to be successful in the long term with these patients with a model that's already, you have biased in your predetermined understanding. Oh, I know it's parasites because everything's parasites. Well, guess what? Not everything's parasites. Okay, so there's stages of autoimmunity. We're going to get to the case study. I'm just laying a foundation here. All right, so there's 3 types of what we call autoimmune, or 3 stages. The first is what we call silent autoimmunity. You have elevated antibodies, but there's no real symptoms or loss of tissue. The second one is where a lot of people come to see us. Well, they can see us there too. Sometimes we just don't know it. And sometimes if we don't check, we don't see it. But anyway, autoimmune reactivity, elevated antibodies with symptoms and no clinically noticeable loss of tissue. So in other words, if you take an x-ray on them, do an MRI, do a CT, do some kind of scan, you're just not going to see anything. But they have the antibodies and they have the symptoms. A lot of this can be seen with Hashimoto's, things like this. Autoimmune disease, when you've actually crossed over and it goes from a functional problem, like you see into, and you can actually look at it and observe it in some kind of imaging, some kind of process, then we call it autoimmune disease. Okay, so I do have a question here, but I'm going to, at the 7:30 time, I'm going to entertain questions. All right, so the treatment strategy of autoimmune disease may need a different approach from conventional protocols. We have well-established, and this is that infectious disease model I was talking about. We have well-established protocols for infections, for oncology, metabolic diseases, diabetes, things like this, right? Transplantations, which are often used as models for management of autoimmune disease. Studies and observations suggest that, in contrast to diseases used as a role model, autoimmune disease has wide variability, different causative and pathogenic processes, which is highly dynamic, making the current treatment strategies to fall short of expected complete remission. Well, that pretty much says it all. Plausible autoimmune disease factors. Actually, I think this illustration came from this paper, I do believe, and I like the illustration so much. Here's autoimmune disease that's in the middle, but then you look out here and you look at, you have genetic susceptibilities, you have environmental factors, you have dietary stress, you have unknown factors. All of this goes together, this compilation of a soup that we call autoimmune. So for us to be successful in autoimmune, we need to address as many of these problems as we can address so that the body has the best ability, the immune system has the best ability to act normally. Okay, so patient management of autoimmune disease. I'm going to go through this. Here's how I do it. By the way, this slide is worth its weight in gold. This slide right here is the take home. This is the slide. Now, you might find a better, more efficient ways to work through autoimmune processes. You could do that. This is a model that I have developed. This is a model that I follow. So if you don't have a model, this is a good place to start. And then you work with enough autoimmune cases, and then you can start tweaking it, take some things out, add some things, do it based upon, the clinical things that you found along the way. So what I find very important is, first, when somebody comes in, are they diagnosed or undiagnosed? Some people come in and they say, I have Hashimoto's, I have rheumatoid arthritis, I have lupus, and it's already been diagnosed. And so you just go to stage 2, so step 2. But if it's undiagnosed, I'll give you some hints later in the program to show you how to tell. Patient education. This is probably as important of a piece of anything, and don't overlook this. This is why some of you people, and I feel like I'm pointing my finger at you, but this is why some of you people are losing patients that have autoimmune. It's all on the front end. We have to educate the patient on the front end. We have to tell them all the bad news, and we've got to tell them as many scenarios we can see. When you come into me as a patient and you have an autoimmune disorder, and I suspect you have one, the conversation is going to vary depending on the case and the nuances that we need to delve into. But it's basically going to look like this. Mrs. Jones, you have an autoimmune disorder or autoimmune disease. There's no cure. There's no known cure for autoimmune disorders. It doesn't reverse. It doesn't go away. Now, I know that's not cheery, and I completely understand it. But if we can identify as many factors that's driving and pushing your immune system to go off the rails, we can help you have a much better or a better quality of life. That is our goal. Now, in some cases that somebody comes in, we can actually get them, they're doing the work we're doing, they can get to the point where they just have a normal existence and they don't really feel. They have to pay attention to some things, but they can resume to some normalcy. Or there are some cases that they're really never going to get back to the normalcy, but it's just about managing these cases well. Now, when you talk to a patient, you're going to kind of know what bucket they're in when you get started. Somebody's had long-term problems, multiple issues. They've had restrictive diets. They've been to 17 doctors. Don't tell this person that you're going to get them where they just don't have any problems, because you probably aren't. But you educate them and say, this is an investigation. You've got to stay. If you're going to do this, we've got to stay with me long enough for us to get to where we need to go. What we're going to do is I'm going to go through the most likely things that are causing problems, and we're going to help you build a strategy for life. That's the whole thing. This is not about you coming and seeing me every 2 weeks for the rest of your life. It doesn't work that way. You're going to come in here, and yes, we're going to see you over a period of time. And when we do that, it's about building a strategy so that you know how to take care of your body, and you know how to manage this the best, because at the end of the day, nobody knows your body like you do. And my job is to walk alongside of you, be a coach, you be an encourager, be an investigator, do these things so that you can get in a better place. And if they say, you know what, that's not satisfactory, I'm walking out the door because you said you can't help me, that is fine. Good riddance, because guess what? That patient was going to be a problem for you. Most people who are reasonable are going to listen to that and say, thank you, doctor. Appreciate you being honest and straightforward. And that way, when you get into a rough spell with this patient, and if it's a hard autoimmune, you will. There's no question about it. There's no like, oh, I start with a patient here, they have autoimmune, they're up here, and we just high-five each other, and we live here for 20 years, and I'm awesome, they're awesome, and everybody's awesome. It doesn't work that way. This is what autoimmune looks like, right? So we manage it the best we can. Now, you might just say, I'm done with this webinar because I thought I was going to learn how to cure autoimmune. Well, you're not going to, because that's not plausible. But we can get it in a manageable state, and we can also get it in some cases. In many cases, we can get it where it's not a life burden and they're not really having as much trouble with it. The earlier we get it, usually the better. Okay, so that's the patient education. I'm going to walk through these other things, but we always go through the bail them out. I want to know what's going on with the diet, triggers. I want to know infections, environmental exposures, life management. I want to know what's going on with these. And every time I have a autoimmune case, I just want to lay this out real quick and say it this way. If I have an autoimmune case, I always go through the top 4. I always go through this. Depending on the depth and how far I have to go, these come next. So somebody comes in, they're newly diagnosed with Hashimoto's, and I'm the one that diagnosed them. They're not having a lot of problems. They're a little bit tired. They're bloated. They're fatigued. They've got some brain fog, right? But it's not extreme. We're okay. We're probably going to be able to do a minimal process with them, and I encourage you to do that, because we don't need to do the kitchen sink if we don't need to do the kitchen sink, because they'll get tired of you. They'll get tired of doing the full program and they'll give up. It's about patient management, right? Give them a good diet. Find out what foods they're sensitive to. Find out if they have infections. Make sure they're not drinking out of plastic, and make sure they're getting plenty of rest and they're exercising and do the things they do. Make sure they don't have anemia, their blood sugar is good. Make sure the liver's working good. Make sure the GI tract's, the digestion's good. You're building the microbiome. Do these basic things, and you're going to find most of the autoimmune do very well. Some of them, that's not enough. When they come to you, guess what? They've already done all this. They've been to 17 functional medicine doctors. They've been to 3 diopsies. They've been to this. They've been to that. And so they've already done these things, unless they've been to the parasite doctors and the heavy metal doctors and the Lyme doctors. Well, then you still go through this process, because guess what? The Lyme doctors, parasite doctors, other doctors don't generally go through this as much, because they go straight to those things. I'm not trying to be caustic with that. It's just a reality. Now, these right here are more specialty items, and I will talk about those in a little bit. Let's get on with the case study. Okay, this is the one of the DAPSI students, doctors, sent this to me, and this is exactly how it was sent to me. So we're just going to walk through this case as if me and you are walking through it for the first time. Okay, so let's do it. All right, so 38-year-old mom of 3. She's 5'6", 120 pounds. So she's pretty thin, right? That's what it looks like to me. My first thought when I see that, I wonder if she has low blood sugar. That's my first thought, because if you have low blood sugar and you have autoimmune, you're not going to get appreciably better with that autoimmune unless blood sugar is better. Now, if you get the blood sugar better, it may not solve problems, but I can assure you this: if she has low blood sugar or blood sugar crashes, reactive hypoglycemia, she's not getting better until that is improved. That's one of the foundational elements that has to be taken care of. We're going to see when we get to the labs. But here again, me and you are just walking through this. All I see is the history. I don't have labs. I don't have anything else. I'm just saying I see that, and I am suspicious. She's a mom of 3, 38 years old. Now, if you've been around moms of 3 that are 38 years old, it just is the reality. When you're 38, I'm sorry, it just is what it is. It doesn't happen with everybody. Don't send me hate mail. But when you're 38 years old and you're female and you've had 3 babies, things begin to change in your body, and it becomes more and more difficult to hold on to that 120 pounds. It's just a reality. Yes, you can do things and so on and so forth. But okay, so complaint of burnout as a nurse. That doesn't tell us a lot, other than she probably just doesn't like her work as much anymore because she doesn't feel well. Thyroid, I don't know what that means, but maybe she's been told she has a thyroid problem already. She has fatigue, brain fog. Guess what? That goes with that definitely goes with low thyroid. What are the most common symptoms for low thyroid? Fatigue, weight gain. She doesn't have that. Fatigue, weight gain, brain fog, dry skin, constipation. Those are kind of the most common. There could be other ones, but of course. But those are kind of the most common. Let me rip through that again. Fatigue, weight gain, brain fog, itchy skin, and brain fog just got me. So, and the last one's constipation. There you go. So irritability. All right. What is irritability? Well, if your brain, let me just say this, I'm assuming too much, but let's look. She might have low blood sugar. If you have, let me get to a blank page here. All right. Okay. Let me just look at this real quick. We're just doing this for fun. Whoops. Okay. So here's the brain, nose, and the mouth. Here's the frontal lobe. This area right here is the orbital frontal. This is the orbital frontal lobe of the brain. The orbital frontal lobe takes care of things like emotional regulation, social skills, attention, motivation. Now watch this. Motivation. Let's go back now that I just said that. She has a complaint of burnout as a nurse. And right here, we have a place that controls motivation, right? Now, guess what? If you have, and I'm just saying this scenario, we don't know it yet. We're going to look at the labs. If you have dropping blood sugar, right? Dropping glucose, then what happens is this part of the brain doesn't have enough energy to properly gate different things. I don't want to get too complicated about this, and I'm sorry if I've gone too far on this, but down here you have what's called the limbic system. The limbic system is always trying to tell you to do things, right? It's your anger spot, it's your happy spot, it's your extreme emotion part. The limbic system is in chronic or constant communication with the orbital frontal. Orbital frontal, 90% of what it does, it's got its foot on the brake, so you're not having road rage, so you're not getting ticked off at the least little thing. You're not getting agitated, right? So if you don't have good energy for the brain, then all of a sudden you have lack of ability to modulate with your orbital frontal, so you get irritable, right? Reflux, this is an important one for you, because if she has reflux, something you have to consider is how's her digestion? How's her HCl? How's the digestive enzymes? How's the bile flow? Does she have food sensitivities? You got to know that. Just look at that. Depression. Well, depression and anxiety. Well, she has, okay, so this might be a little bit of a stretch at this point, but we're going to check it with a physical exam, and that's this. My thing's not working as well as I would like it to. So here we go. Let's try to encourage it to do better. Okay, so down here you have the thyroid. If you have Hashimoto's, sorry about the red color, man, that's really bright. Let me try a different one, kind of ease that up a little bit. Okay, so if you have Hashimoto's, the antibodies that attack the TPOs is the same antibody that can also attack the cerebellum, the Purkinje fibers of the cerebellum. Purkinje fibers gate functions in the cerebellum. Long story short, it goes this way. If your cerebellum's messed up, it can drive panic, anxiety, depression, and all these things, because the cerebellum feeds right into the frontal lobe and turns it on. If you've got a cerebellum that's not working well, then you could have anxiety, depression. Now, it could be from other reasons. If you could have reactive hypoglycemia, and it would cause this. You could have, I don't know, I'm throwing things out because me and you are working through this case. These are all the things that if I looked at this, I wouldn't take 20 minutes like I've taken here. But in a matter of about 20 to 30 seconds, I would look through this and my brain would be calculating all this when I go in to talk to the patient. She has heavy periods. Okay, if she has heavy periods, that really makes me suspicious of what? Blood sugar. Dropping blood sugar. Lack of motivation, we talked about that. That could be the orbital frontal. Hair loss could be thyroid. Recurrent BV. I don't know what BV is, so I can't really talk about that. Evaluated for hearing loss. The ENT found nothing. Told ENT, okay, the ENT said you have adrenal fatigue. Well, I mean, maybe. We don't know. We can't say that yet. Don't just give her an adrenal glandular and think that this is going to get better. And I'm not trying to be a smart aleck, but you know, that's what some people do who take, you know, the type of work we do, and instead of using drugs, they use nutrition. In other words, oh, you have adrenal fatigue, take an adrenal glandular. Oh, you have thyroid, take a thyroid glandular. Oh, you have this, take that. See, it's the same infectious disease model. We're just doing natural things. I try to encourage people to go through the functional model. And I've got a message right here from Annette. I better look at this. I hear you. I hear you. Okay. Oh, ha, ha, ha. Thank you, Annette. Okay. BV is bacterial vaginitis. That totally makes sense. Thank you so much. This is why I have Dr. Annette here, and I'm so thankful she volunteers to do this, and I'm so thankful. Oh, by the way, I volunteer to do this as well, but I'm not looking for anything. I said the volunteer thing, and I was like, hey, this is volunteer. Okay, all right, so yeah, bacterial vaginosis, that's important to know. So she has recurrent infection, but guess what? If she has recurrent bacterial vaginosis or vaginitis, we've got to get this under control, because if we don't get this under control, she's going to have a constant inhibiting. She's going to have chronic problems with her immune system, because she's just going to be in that place where her immune system's trying to fight this, but it can't fight it. It weakens it, and then it starts getting crabby and starts going after things it's not supposed to go after. Okay. Okay, so she has 2 children. If you look at the bottom here, she has 2 children with type 1 diabetes. So what does that mean? It's genetic. There's some genetic. Okay, so I shouldn't say it that way. She has genetic predispositions, and so do her children. So guess what? That doesn't mean that her children had to get diabetes mellitus. They didn't have to get it. If those triggers and if those different things could have been avoided, there's at least a chance that they would not, a good chance they wouldn't have gone into that. Okay, so let's look at this. I'm going to erase patient management. Looking at what we see so far, what would we do? Well, she does have, okay, so she does have, and I'm trying to get my pen to work. It's not cooperating with me so much. Okay, so she does have a diagnosis of Hashimoto's. I would patient educate her. She's been suffering with this for a long time. If we don't educate properly, we're liable to lose this patient. So she's a nurse, so she may or may not be. Some of the nurses are my best patients, and some of my nurses are my worst patients. We're going to take questions in just a second. Okay, some of my patients are good, some of my nurses are bad for patients, right? So I don't know where she's at, but if she is a nurse that's kind of steeped in traditional model, then she's going to give you a few visits and go down the road if she doesn't feel like she's completely well. And guess what? This is a case that might not get completely, might not see a lot of results right away. Maybe so. Her blood sugar is bad. She has bacterial vaginitis. She's got different things going on tangibly that I can see we could probably work with that would help her improve. So we'll just have to see. All right. So what am I going to do? Well, I'm going to do my blood work just to look at things. But when I look at my blood work, I'm really going to focus in on looking at Basal-Mount. I want to look at the Basal-Mount model. Okay. And of course, I'm going to be looking for infections. I'm going to be looking for other things as well. But let's just see, and basics. I just need to see basics. So let's take a look and see what we see. Here's our blood work. All right, so we have cholesterol. That's a doozy. That's a doozy. Cholesterol 122. What I call that is very bad. What does cholesterol do? That helps you build your hormones. If you can't build your hormones, you can't be healthy. So not only that, but the brain has to have good amount of cholesterol to be able to function right. So guess what? She's going to have poor brain function on top of hypothyroid, which gives you poor brain function. She has a double whammy. She doesn't have enough cholesterol. Cholesterol is in the membranes of the neurons and helps you communicate neuron to neuron. When it comes down to, it's all about communication in the brain cells, right? So our HDL, I can't really see it. It looks like 56. So if we look at this right here, her cholesterol to HDL ratio, I apologize, I don't have time to go into a lot of this, but if you've seen my teaching, you know that we teach that the perfect cholesterol to HDL ratio is 3.1. When you go lower than that, it means there's immune dysregulation. Well, hello, she has Hashimoto's. So there's some definite immune dysregulation. Her triglycerides are at 64. She's not absorbing fat. Her LDL is way low. I can't see, it's 52. It looks like. My eyes don't work that great, so I'm resisting putting glasses on. So, but anyway, so you know what? Let's do, because I forgot to do this. I'm going to take just a moment. Dr. Annette, do you see questions there that we can answer before we go further into this? If you do not have questions, I will move forward. But I do see one question here. What's that? Go ahead.
I don't see any on my end, but.
Okay, so I'm going to look here. Okay, so I don't see any at the moment, so let's go ahead and move forward. So now, let the record reflect. I answered all the questions. Very good. I'm joking. All right, so here we go. The magnesium, we like to see that magnesium. We like to see that magnesium 2.1 to 2.4, and she's at 1.8. What that means is magnesium is a buffer for an acidic environment. Inflammation causes acidic environment, so that just means that she is inflamed. We kind of know that. Phosphate, nothing to see here. Uric acid is a bit low, but I'm not too crazy about that. Immunoglobulins are low. So if you have to do a food sensitivity on this patient. But when you do food sensitivities, you're going to have to recognize, because that immunoglobulin's on the low end, she's going to be a low reactor. So if you do all tests and go through doctor's data, if you go through PINK, which you should, because you save money doing that way, and it doesn't cost you any money to be a part of PINK. So if you go through PINK, and we have information, you can contact me. Actually, Dr. Annette here in a minute can give you information about that. But if you go through PINK, they use a lab, and what I would do with that is I would initially use everything that's 0.185 and above. Usually the break off is 0.2, but when you have low immunoglobulins, you have to use those lower ones because she's going to be a low reactor. Okay, so her TSH, okay, all that TSH means to me is she's probably taken at least a medication. I didn't get a medication list, and I didn't get a physical exam either, but that's okay. We're working through what we have. So this is probably they're taking something, whether it's a thyroid glandular or whether it's levothyroxine, Synthroid, something like that. Okay, so she does have TPO that's positive, so she is Hashimoto's. All right. So glucose, I suspect this is fasting. It is. It says yes up there. So her blood urea nitrogen is at 11. And what that means is this. If you remember going through this, remember proteins are always remaking themselves. You're always making new proteins, but they're always breaking down. When they break down, they go to the liver reconstitutes them, makes new proteins. But when you break protein down, they're full of nitrogen, right? And so that nitrogen, if you leave it by itself and bumps up against some hydrogen, you actually make ammonia. Ammonia is toxic, of course. It goes to the liver. The liver makes BUN out of it. So when you look at blood work, if your protein's reasonably, in other words, if it's reasonably not too low, then the BUN should be 13 to 18. When it's lower than that, it means the liver is congested because it's not processing the BUN. So let's go down and see if we can cheat real quick and look at the protein, if we can see the protein. Okay, so the protein's 6.2. So I actually made a big deal out of that, but it's probably not a big deal because her protein's so low because she's not absorbing it. She has GI issues. She's not absorbing protein. She's probably gluten sensitive and whatever else. You got to find food sensitivities for this patient. Okay, so BUN, I wouldn't make a deal out of that, although she probably does have a congested liver. Looking at the transaminase, that should be 18 to 26, it's 13. So she does have that, but what we're not seeing is BUN is actually, even though it should be 13 to 18, because her protein's so low, that's actually normal. I just wanted to make that point because it's an important point. Okay, kidney function is good. Sodium is down a little bit. I'm not too excited about that. It's 139. If you look at that sodium right there, calcium is okay right there. Here's a dandy. Look at that globulin. Why is that globulin so low? Well, because her immune system is completely beat up. She has a beat up immune system, and that's something we might have to address. I'm not going to address it initially, and I'll explain what I mean. I'm going to do my bail them out foundational work. If I don't get where I need to go with foundational work and that doesn't start naturally rising, then I will use things like colostrum. I'll use things like beta-glucan. I'll use things that are, as long as it doesn't coincide or conflict with the Hashimoto's and the autoimmune, I'm going to use herbs that'll help build up the immune response. I'm not going to do that initially because I believe in fixing supporting systems and letting the body heal itself. So that's how we're going to handle that. Okay, so the alkaline phosphatase is low. All right, well, alkaline phosphatase should be 60 to 80. Keep in mind, you found alkaline phosphatase in the bones and you find it in the liver. So it has to do with bone turnover. So the faster you're turning over bone, the more alkaline phosphatase you're going to have. That's the reason why when somebody has a metastatic cancer to the bones, your alkaline phosphatase can raise because you're making more bone. Or if a child is growing, bones growing, alkaline phosphatase will raise. Now, if it lowers, it can be a zinc deficiency, but in this case, it could be zinc. I would have her do a zinc tally test just to see, but a taste test with zinc if you know about that. But what I would do with this is I would suspect, since she has Hashimoto's, it's probably low metabolism coming from low thyroid function, and low metabolism is going to make bone slower, and because you make bone slower because you have poor metabolism, you're going to have a lower alkaline phosphatase. Now here is the zinger. I don't want to congratulate myself too much here, but it is an important fact to point out that she has absolutely terrible, terrible, terrible blood sugar. She's not getting better until that gets better. LD is something, it's under 100. I don't know what it is, I can't see it, but it's under 100. All right, so let's look here and take a gander. All right, so here we go. So we only have about 4 to 5 grams of glucose in our blood at any given time. Think about it. If we have 5 gallons of blood, we only have a teaspoon of sugar. That's it. If you go up to 8 grams, you could go into a coma. If you go less than 2 grams, coma. So there's a very tight range that the body's actually going to use to do, right? So the average meal is about 75 grams. So you can't go straight from there into the blood because you go into a coma. So the liver is the great regulator of blood sugar. The more blood sugar you have in your blood, the liver will try to consolidate and store it. If your blood sugar goes down, your liver's going to let go of it. That's pretty much how it goes. So sugar comes in here, your liver has a massive job to do. And this massive job does this. This massive job is this, is it needs to get this sugar in there and store it. 95, 98, depending on how much you eat, of the sugar that you eat when you eat a meal has to get stored in the liver immediately, and only 1, 2, 3, 4, 5% actually goes into the blood where it gets into cells and gives you energy. Okay, so as it turns out, one of the pathways to convert sugar into energy is the pyruvate to lactate pathway, which needs the enzyme lactate dehydrogenase. If lactate dehydrogenase goes below 140, it is a very good indicator, unless somebody's on no or very low carb diet, it's a very good indicator that that enzyme is underemployed because the sugar is crashing in between meals. So that is actually a very important factor for this patient, because if your sugar is crashing in between meals, it's screwing up your hormones, it's screwing up your adrenals, it's screwing up your thyroid, it's screwing up everything. So in other words, 85 is good fasting sugar. You should eat and sugar goes down because you consume it, and then your liver lets go of sugar and you call it a day. What she's doing, she's going up, her liver's not letting go of the sugar, it's drifting till it hits here. Then you get a surge, a cortisol surge for sure, but a glucose surge. And let me take just a moment and look at this. All right, so here is the brain, the nose, and the mouth. Here is the hypothalamus, and here is the pituitary, okay? Now, here's a kidney. Above the kidneys, you have the adrenals, right? So when sugar drops, I'm sorry, I'm writing with my finger because my pen's not working. Your hypothalamus pituitary sends an alarm called ACTH to the adrenals to kick out cortisol. Cortisol is the great modulator of blood sugar, blood pressure, in the immune system. The more cortisol you have in your blood, the higher your sugar, the higher your blood pressure, and the lower your immune response. The lower it is, just the opposite. Cortisol comes back here and feeds back to the pituitary, so the pituitary knows how much, knows the cortisol is released, and then it begins to block this signal, and you stop doing it. Well, the problem with it is this is the HPA axis. That's also connected to the thyroid, which is the HPT axis. It's also connected to luteinizing hormone. That's where the man makes testosterone. That's where the woman kicks off ovulation. You also FSH, which for the man makes the sperm, for the woman makes the eggs. You also have growth hormone. So when you screw this, and let me just do it this way. When you screw this loop up right here, you begin to develop pituitary fatigue. And now what happens is, as a result, now all the rest of these loops get messed with. So you have somebody with, okay, let's back up. The ENT doctor said, oh, I know what it is. It's adrenal fatigue. Well, he or she wasn't completely wrong. There probably is some adrenal fatigue there, but you're not going to get anywhere by just giving this person adrenal glandular. Why? Because that's not what's causing the problem. The problem is here. The problem is here. Of course, the adrenals are down. If you support them, it may help some, but it's not getting to the root of the problem. You have to go through the process of supporting the blood sugar. Okay, so anyway, blood sugar is a big deal. So let's just summarize what we've seen. She is not absorbing fat. That's a big deal. She's not absorbing fat. She does have Hashimoto's, and her immunoglobulin is down, all right? And she has low blood sugar, so that's an issue. She has low immune function because her globulin's so low. So here's some things that we know just looking at this. These are foundational things we're going to have to deal with. If we don't, we're not going to have success with the case. Her insulin's 7.4. I don't care so much about that. Her iron's good, her ferritin's good. C-reactive protein is good. So, which is interesting because she has bacterial vaginitis. So, just interesting. If you look at her differentials with her neutrophils, lymphocytes, there's probably infection in there. But right now, we know that if there's bacterial vaginitis, we go after it. But if not, let's stay with the other foundational elements first. White blood cells look okay. All of this really, I mean, you could pick it apart a little bit, but not bad. Okay. This is a later date. It looks like, yeah, this is perfect. She goes to the traditional endocrinologist, and the endocrinologist says, "You're fine," right? On the thyroid there. Okay, so here's another, I'm not sure what this is right here. Oh, so urinalysis, nothing to see. Here's another later date. Cholesterol still low. That's still low. Everything's still low. Okay, her vitamin D is there. She's probably supplementing with vitamin D, I would suspect. Okay, chloride. Okay, here again, it's another blood test. Globulins are low. AG ratio is high. Her immune system's kaput. It's probably been fighting things so long, it just does not have the stamina to really do anything. The TPO antibodies are still high. Her sodium now is beginning to wane. Why would that be? It is more adrenal fatigue, but you're not going to solve this problem by just going to adrenal fatigue. Okay, I think this is an interesting, and it's actually a good test to run. This is the CD4 to CD8 ratio. This is CD4 CD8 ratio. Now remember, if this is low, and let me see if I can get my different pen. If this is low, then it means that you have immunodeficiency, immune deficiency. If this is high, it means your immune system is overactive, like you're fighting an infection, or your T8 cells. Remember, they're the suppressors. They're the CT toxic. So if that's high, it means that you're not regulating this process well. Okay, and I don't really see much there. I think that's really at 2.4. That's really okay. It's kind of middle of the road there. Okay. Oh, well, the plot thickens. Look at this. ANA is positive. What does that mean? Well, this is what it means. You have a DNA, and if you have an anti-nuclear antigen, that means you have white blood cells that are actually going after the DNA. Now, believe it or not, some endocrinologists will look at that, and if there's no other symptoms, they'll say, don't worry about it. It's just a positive. We don't think much about it. But guess what? I think a lot about it. If you have antibodies that are actually attacking your DNA, I can't think of a worse scenario. Okay. All right. So viral capsid was positive, nuclear antigen. But, to really know Epstein-Barr, to know if Epstein-Barr is positive, and by the way, I don't know if this patient has a history of mono. If she does, then I would definitely be going down that road. But looking at the Epstein-Barr, you need to see what's called the early antigen. That's really the one that's going to tell you if it's activated or not. The viral capsid could be positive. The nuclear antigen could be positive and you still not be activated. So you need to really know that. So you need to do that early antigen test. So I think it's called EBV-EA, early antigen. Okay, so here's some other things. Let's just move on because I think we've seen enough of this. All right, so I think we've got the picture. All right, so what do we do with this? I think that's good. All right, so let's look at some of the things that we know. All right, and I'm going to go back to here because I actually drew some things out a long time ago. Okay, so we know from a very basic foundational issue that she does not absorb fat well. So she has some liver gallbladder problems. I didn't see whether she has gallbladder or not. Maybe she does, maybe she doesn't. But in any case, she has very poor bile flow. She has a very weak immune response, and we can lump these two together. And she has poor blood sugar, dropping blood sugar. Now, from her history, she has reflux, right? So we know she has basic digestive issues. Well, we know she has basic digestive issues because, now, keep in mind, what does the metabolic assessment look like? Remember, we go through that, we make a big deal out of that, right? So let me just say this. To start with this patient, there's a few things we're really going to have to do, and that's this, that we know of. Based upon the bale amount, there's a few things that they're just kind of must. Number one, we must get blood sugar under control. That's number one. Number two, we have to get basic digestion working, liver GI. We've got to get liver GI basic functioning going on. We do have a low immune response, and there's at least a possibility we have a chronic infection. We don't really know that with the information I have right here, unless she has active symptoms in the area of bacterial vaginitis. If she has active symptoms, I know she has itching, she has discharge, she has something that would clue me in, then I would go after it. But if she really doesn't have any symptoms right now, based on the CBC, at this point, I wouldn't do it. At this point, what I would do is this. I would, number one, if you've seen my process, I like to go through a 12-week process, right? 12-week. So very first, we're going to start with blood sugar boot camp. But we have to figure out what food she's sensitive to, right? We are going to, work through the process of HCl, digestive enzymes, and bile flow. Whatever we need to do. Do we need to use artichoke? Do we need to use beetroot? Do we need to use ox bile for the bile? Do we need to start with apple cider vinegar and work our way up to HCl for the HCl? Do we need to give her digestive enzymes? And I'm going to say, yeah, all of the above. I'm going to do all of that. I probably won't give her ox bile because ox bile can be harsh if it's more unpredictable. So I'm going to do all my digestive stuff. And I'm going to do blood sugar boot camp. I'm going to follow food sensitivities. Then the next step we do is we're going to look for triggers. We want to see dietary triggers. Of course, that would be my food sensitivities. For infection, if nothing shows up, then in 4 weeks to 6 weeks, I will rerun my CBC after I've had chance to calm down inflammation a little bit. The CBC will probably give me a more true picture. I will educate her on basic environmental stuff. I will be talking to her, making sure she's able to sleep good. And I think in her history, she's not able to sleep good. Guess what? If you have low blood sugar like that, you're not going to sleep good. Why? Because your brain is crashing in sugar in the middle of the night. Your cortisol raises, you're going to wake up. So you have to deal with blood sugar, right? You have to do that. And by the way, I have a blood sugar sheet we use along with blood sugar boot camp, where a patient can take it home that just gives them tips. Here's how you handle dropping blood sugar to prevent that, right? But this patient has to be improve with that, or she's just really not going to get better. So, all right. So those are the things I would do to absolutely start with this patient. I would go through blood sugar boot camp. And that's basically a protein, an amino acid. It has some L-glutamine in it. It's a basic process to help the liver uncongest and help regulate blood sugar. It's 2 shakes a day. I always suggest they do it in the morning and noontime. Make sure they're eating enough, and they have to have protein with every snack. But if they're dropping blood sugar, they have to eat multiple snacks through the day. If they're having trouble sleeping, you want to make sure they eat a snack before bed. Try something like a complex carb. If that doesn't work, try some a chicken breast. Try protein, a fat. Figure out what works for that patient and get them sleeping better. Okay. So now let's go back to here, because there was one more test that was run here. And here was the test. All right, so this is a cortisol test where you check the cortisol 4 times in a day, right? You look at I'm looking at my numbers, okay. You do the cortisol 4 times in one day, and you check it out first thing in the morning, you do noontime, 4 o'clock, and then nighttime. And you want to see what this swing looks like, right? So what she has here is what's called a broken circadian rhythm, right? What controls the circadian rhythm, sleep-wake cycle? It is cortisol, right? So when she wakes up in the morning, her cortisol is low. If your cortisol is low, what does that mean? That means you're not getting enough sugar and oxygen to the brain. You don't have enough fuel for the brain. So guess what? She's tired when she wakes up. Of course she's going to be tired when she wakes up. But this broken circadian rhythm is causing her difficulty in being able to sleep properly. Now, here's what I would do. Since you've run this test, this is what I would do. You have to manage blood sugar. You've got to get food sensitivities. and do basic digestive things. Make sure HCl is good, digestive enzymes, bile flow, follow food sensitivities. These are basics, right? These are basics. But what I would do in this patient, after I go through the first 2 weeks of blood sugar boot camp, I would have this patient at 2 o'clock. At 2 o'clock, I would have this patient take something called, it's a cream, it's called Adrenocalm, and you can get it from Apex Energetics. I would have her do the cream on her wrist or someplace where there's not a lot of fat. Have her do that at 2 o'clock. The reason why is because Adrenocalm is phosphatidylserine. Don't have time to go into this a whole lot here, but the hippocampus is what the hippocampus, and let me just do this. I'm sorry, but it's going to take a couple extra minutes. We just have to go through this. So here's the hypothalamus, and here's the pituitary. Here's the pituitary. The hippocampus sits down here. That's the hippocampus. All right. Now the hippocampus is actually rich with cortisol receptors because the hippocampus is what determines this cortisol swing. It's what determines your rhythm of the cortisol swing, the circadian rhythm. It's what determines it, right? Well, as it turns out, cortisol gets released in surges when you have drops in blood sugar. Well, all that cortisol goes to the hippocampus, and then the hippocampus becomes fatigued, and then it loses its ability to regulate the sleep-wake cycle, and people don't sleep good. So what we do is, number one, we have to get the blood sugar better. I should say control, but stabilize blood sugar so we quit having these cortisol surges so the hippocampus can be happy. And by the way, that's why she gets brain fog as well. There's another reason too, but let's just keep it there. All right, so the hippocampus, phosphatidylserine is actually good food for the hippocampus. So if you give this patient phosphatidylserine in the form of Adrenocalm right here, what it'll do is it will block that raise of cortisol. And if you block it there, it's counterintuitive, but that'll bring it down, and that'll help that rhythm come to normal. And if it normalizes, then you get back into a rhythm. I would not do that until I did my blood sugar work first. Okay. All right. So, here, I look at this stuff, and DHEA is off, that's off, progesterone's off, or it could be off. Of course they are, but these are, this test, I love it for the cortisol swing. I don't really use it too much for the other stuff because it can throw you off clinically. It can throw you, it's a red herring. You can start, trying to treat this and treat that, and then you just wind up in a mess because you lose your foundational work. Okay. All right. So that's the spiel on here, and let's take a look here. All right, so this is actually what was done. So let's just look at it. We're not going to be critical of this because I actually think this, I looked at this briefly, and I think they did a reasonable job. They had them follow a paleo diet with frequent meals. That's good. They were going after blood sugar. That's good. Adrenal support, I don't think it's a bad idea. You just don't want to stop there. GTA Forte, not a bad idea. Probiotic. Okay, so I would probably, I don't see food sensitivities here. Maybe that was done, but that's a must. If you miss that, that's kind of like if you're playing Monopoly, don't pass go, don't collect $200, go straight to food sensitivities, because you're really not going to have success with these cases if you don't identify food sensitivities, because it could be the reason why the immune system's all ticked off. So we have to work through it that way. All right, so so let me just go through this very quickly here, okay? All right, so first and foremost, let me back up. I'm sorry, there was one thing we need to get. All right, so watch this. Felt less fatigued in the morning. Why? Because her blood sugar was better, and she was probably fixing that circadian rhythm without using the technique I told you. She was just getting blood sugar better by simply doing this, all right? So she was getting better. She began losing weight, and her TSH dropped. I removed her from the GTA. Now, I'm not being overly critical on here, but I probably would not have dropped her from the GTA, just because if you have thyroid and you have Hashimoto's, you have white blood cells attacking the thyroid. You might not use Forte, but at least use GTA, because if you put it in the system, the white blood cells will have a tendency to attack the GTA. And when it does that, it attacks the thyroid less. So if you can use a glandular, if it's a gland that's being hammered from an autoimmune, use a glandular, and it becomes a false flag for the immune system. So I would keep that on. And here, I'm not being critical. Don't hear me say it, because I think you did a good job on this workup. All right, I added gut support, L-glutamine, immuno IG, SBE, and also progesterone drops. I probably would not have done the progesterone drops. And the reason why I probably would not have done that is because I feel like the biggest problem here is really going to be the dropping blood sugar. Let's really work on this. And she stopped after 4 visits. Well, that might have been just because she's very medically minded, and after 4 visits, she's like, okay, it didn't work, and she went on. Too bad for her, because you could have really helped her, and you were already on a good track of doing some good work here. So, but that being the case, always go to and think about this one equation, and that's patient education. In the beginning of the care, you have to make sure that the patient understands what's going on. You've been sick for a long time. Autoimmune is not reversible. In many cases, we can get it where you can manage it well and feel well and have good quality of life. In some of them, we can't get you all the way, but we can manage it better than you're managing it right now. My job is to go alongside with you, coach you, encourage you, be an investigator to help you build a strategy so that it will work for your life. It's not about you coming in here every 2 weeks for me to say this, that, or the other, but it's about you coming in over a period of time for us to develop a strategy that works for you. So that would be my spiel. All right. So as far as the bail amount, history, I'm just going to skip through that because we don't have time. Sorry about this. Okay, so foundational. For autoimmune bail amount, here's things you have to pay attention to. Blood sugar, get them adjusted chiropractically, get that vagus nerve humming, brain gut axis. Do they have anemia? Are they inflamed? Do they have an infection? Work on the liver, GI, environmentals, estrogen, and microbiome. Okay, so I'm sorry, my thing didn't do this. Microbiome, yeah, I'm just going to skip through this because you've kind of done this. If you want this stuff, I can give it to you. But food sensitivities, you have to do food sensitivities and work through that. In the cases that, you do all this work, you do this top 4, and it's just a more complicated case. Now you have to evaluate the GI system very specifically. You've got to know whether they have autoimmune. You have to know whether the GI tract has infection. You have to know whether they have oral tolerance, not a leaky gut, but oral tolerance, and the dendritic cells are overactive. You have to know if there's a leaky gut. Now, keep in mind, most of my autoimmune cases, I can do this top part, and I am good as gold. But I get about 20, 30% of my cases, not so much. I've got to get way down deep. And when I do that, I like to go through labs like this. This is array number 2, Cyrex. It shows me leaky gut. Do they really have a leaky gut or not? If they don't mess with leaky gut because they don't have it, right? Not everybody has leaky gut. I know in functional medicine, we all think everybody has leaky gut, but they don't. There's another test. This is array number 14. This is probably my latest, greatest favorite test. It's array number 14. What it does is it checks for leaky gut. It also checks for leaky brain. It checks for foods you could be cross-reacting to the gluten. It checks for autoimmune. It checks for so many things. Don't skip this test. If you have an autoimmune case and they're more difficult, you have to know what's going on in the GI test. It's actually a pretty reasonable test, $300 or $400, really. It's a good test. Get it done. It takes about 3 weeks to get it back. It's a saliva take-home kit, so I'm going to encourage you to do that. And there's some basic things. If you want to just look like blood-brain barrier, you can do this. But I always suggest if you're looking for a blood-brain barrier, just go ahead and do this test because it's in here. Okay. Okay, and that's good. Okay, so what I'm going to do here is let's go ahead and answer questions. Dr. Annette, do we have any questions?
I don't see any.
Wow, that must have been either a really, really great presentation or really, really poor presentation. Who knows? We'll see.
I think they're probably taking notes as fast as you can talk.
Okay, you know what? I went through this pretty fast, and I hope a lot of you guys have already been through the classes. Now, keep in mind, do you know it's May May 8th and 9th? May 8th and 9th. We are having a DAPSI seminar, and believe it or not, we are going through everything that has to do with thyroid. If you want to know about the thyroid and all the ins and outs and adrenals and how to work through that, that seminar is going to be May, I think 8 and 9, or May 7 and 8. I might be a little confused because Mother's Day is actually May 9th, and we actually might be doing that on a Friday evening and Saturday all day. I'm not sure. We haven't settled that, but I will get that information to you. I encourage you to join along with it. You're going to learn a ton of information. You can call our office at 573-341-8292 to sign up for that. And Dr. Annette, what about Pink? What is your Pink phone number? Do you have it?
I do. The office is really busy right now. So if you guys have any questions, you can call or text my cell phone directly. It's 314-650-1300.
Okay, say that again.
314-650-1300.
I'm writing with my finger. So 314-650-1300. Yeah, it's a good place to do it. And like I said, thank you guys so much. Give me some information. I'm going to do this again in a month. And if you want to send me a case study that has to do with something else or some ideas, I have ideas. I know some things to do, but I'd like to hear from you guys if you have some special interest that you would like to actually go through. Give me some feedback. And I appreciate you guys being part of this. And Dr. Annette, I really appreciate you jumping in and helping out. It really helps out a lot. So, all right, guys, thank you very much. And I hope you got a ton of information from that. You guys have a good evening. Good night.